Hello and namaskara everyone. We welcome you all to this wellness forum. Thank you for joining us, and I'm Dr. Lata. We would like to welcome everyone to the Health and Wellness Forum again. We would like to address three essential topics that impact our community well-being: mental health, menopause, and diabetic education for. These are areas that touch many lives, and understanding them better equips us to support ourselves and others. This talk is an opportunity to learn, share, and grow as we work together to foster health, more informed communities. After our talks, we'll have all the speakers come on stage to answer all the questions that the audience might have. Of course, we have limited time, and we would be able to answer the questions later. You can actually approach the speakers. Their email address will be on the slides at the end of the talk. And together we can make a meaningful difference. And now I would like to introduce Dr. Shikha Verma, who is a triple board certified psychiatrist in general psychiatry, child and adolescent psychiatry, and addiction medicine. Dr. Verma is the founder and CEO of Synergy Psychiatric Centers. She serves as medical director of Northern California, and she's the vice president of education at Evolve Adolescent Behavioral Health. Now, Dr. Verma, you can take over from me.
Hi, everyone. Thank you so much, Dr. Kumar, for having me here, and VPA Convention for inviting me to speak on this lovely topic. We are actually in the perfect month right now. The month of July is actually the National Minority Mental Health Month. So here I am talking about depression in our communities and how we can work towards raising the awareness about symptoms of depression and other mental health issues, and address the cultural beliefs and stigma that comes with us. How we can guide our people for the coping strategies, provide them with the resources, and as a community, we can empower them, with the actions, what is out there to help our people out. So what is depression? I think I really want to emphasize that it is not just about being sad or feeling down. It just does not affect your mood only. It also impacts your body, and it also impacts your functioning. So if you look at the WHO's 2023 reports, 280 million people worldwide were noticed to be struggling with the depression. So what exactly are the causes of depression? So in psychiatry, there's a huge thing about the biological factors and the environmental factors, right? So biological factors are the non-modifiable genetic risks that one could have. What we get from our parents, what we get from our grandparents, or the larger extended family. But the environmental factors are the modifiable factors that one endorses from the environment they are living in. For example, trauma, any stress, discrimination, financial difficulties, family dynamics, conflicts in the house, or for people like us, immigration challenges as well. Right? So what happens here? When genetics are in play, when we know that certain people are at higher risk, and then they are also impacted by high environmental stress, they could be at higher risk of expressing the symptoms of mental health disorders, including depression, anxiety, and many other disorders, right? However, when the genetic risks are high and we provide them with a supportive, loving environment, even though there is a vulnerability, we could provide them with the resilience. And those mental health conditions might not express. Or, if they come, they are more responsive to the treatment. Secondly, I think the vice versa is also very true. Let's say somebody does not have any genetic risk factors, right? But they are in high stressful environment all the time. So even though there is no vulnerability, there is still a higher chance that they could express the mental health symptoms. So what exactly is our brain doing? So it's almost like that the Uber drivers of our brain, the serotonin, the noradrenaline, the norepinephrine, or dopamine, they almost go on strike, or they have lost their Google Maps. And that's what happens. When we are working on the treatment, those are the neurotransmitters that we are trying to work on. So I really wanted you to take a look at the numbers here. So the mood disorder prevalence is about 16.9% among the Southeast Asian Americans. And the suicide risk is 5th leading cause of death in our communities as compared to 9th for the whites. I really want you to remember these two numbers, okay? And 70% of the Southeast Asian refugees in care are diagnosed with PTSD. I just threw a number that there because, in California on the West Coast, we do have a very large population of Indian refugees also. So for ages 15 to 24, suicide actually is the leading cause of death among Asians. So our young people, the highest cause of death, the leading cause of death in our community is suicide. So that's why I wanted you to remember, these numbers. Look here. This is the prevalence in the entire US, where white people report that 22% of them struggle with depression. Our community reports 16.9%. But if you look at the suicide ratio, it is different. It's swapped. We are the 5th leading cause of suicide in our communities, and whites are the 9th. So are we still underreporting the symptoms? Are we still not genuinely reporting what we are feeling? And I think that is what I wanted to emphasize in the previous slide. So what are some of the factors across the lifespan that our communities see? So in the youth, coming from the Southeast Asian community, the academic importance is huge. The professional, success is determined by how educated one is. But that brings in a lot of academic stress for our folks. Our younger kids, they come in all the time for how stressful they feel if they get a B+ instead of a B-. It's such predominant in our younger population. The other piece that I hear from them is they really want to identify with their peers. And the cultural values are pretty important as well. So they kind of feel torn between where they're at and where they want to be. In women, women usually have hormonal changes happening from very early on in their life. When they hit the puberty, there are significant mood dysregulations happening, with all the hormonal changes. When they go into their young adulthood, they are supposed to be raising the family. In the childbearing age, when they give birth to the kid, there's a huge change. There is a huge hormonal shift that happens, which predisposes them not only for depression, anxiety, psychosis, but many other stressors along with it. And then comes the perimenopausal and the menopausal, where again, there's a third shift happening between the hormonal changes, which my colleague, Dr. Gora, will be talking about very soon. Men, I think it is very important to say that in our culture, the depression, anxiety is underdiagnosed in men because they are supposed to brave through their emotions. They're not supposed to talk about their emotions because it is considered as a sign of weakness. So how does it come out? It comes out as anger, it comes out as silence, and that only brings family dynamics, complications, and conflicts. Because the anger or the silence is not just related to how they are feeling in the moment, but it is a buildup of emotions through the several months, years that comes out. So that is why I feel like, in men it is really, really underdiagnosed for a very long period of time. And in elderly, people who were once very productive members of our community, they suddenly lose that role. Their age-matched peers, friends, family members are dying at the same time, leaving them feeling isolated and leaving them feeling alone in that moment. So in elderly population, actually, the symptoms of depression present very differently. They're not suicidal. It is more about lack of self-care that how they present. They stop eating, they stop caring for themselves, they really look withdrawn from their usual self. So what are some of the barriers of care that were identified? The fear of shame or dishonor persists. I hear so many times, I left my job for my kids, and they're still feeling depressed. I feel like a failure. And I go back and tell them, it is not about you. It is about how your child is feeling right now. And whatever you have done to raise your kid, it is not a reflection of your failure. Like, let's find out what is making them feel the way they do right now. So it is 50% less likely for us to access care as compared to the white adults. And it is 227% less likely for us to be diagnosed with anxiety disorders and 213% less likely to be diagnosed with depression. So the 70% people who actually, between all this, sought care, they said that 37% still were worried about the stigma that comes with the mental health diagnoses, and 33% struggled with assimilation challenges due to being an immigrant in the country and discrimination. So myths versus facts. There are plenty, but I just wanted to highlight two. First myth that I want you all to remember is depression is a Western illness. Fact is, cultural values can mask the symptoms, but they don't necessarily treat or cure. The second myth is talking about it makes it worse. Actually, the fact is, speaking actually promotes healing because you get to know where it is coming from, how it started and how I can correct it. Remember we talked about the environmental factors, like, how we can support our individuals? So because, there's this big notion that how it is a Western illness, I really wanted to look back into the census and data, what's going on in India right now, okay? So India contributes right now to 15% of the global mental, neurological, and substance use burden. This is the Lancet's report from 2020. 10 years ago, in the National Mental Health Survey, 1 in 20 Indians were suffering from depression. And WHO in 2023 talked about that 56 million Indians suffer from depression and 38 million suffer from anxiety. So these are big numbers. I still feel they are not big enough. And suicide, again, is a leading cause of death between ages 15 to 29, either because our families are still in silence or in denial that our family members could be having it. So are we really able to support our people, our young people, or we are losing them to these grave mental health conditions? But not everything is gloomy. There is hope. Things are getting better. And we can see, I just wanted to compare again between what's going on here and what's going on in India. So India's mental health budget has doubled since 2020, signaling a stronger government commitment. And over 10,000 tele-mental health centers launched under the National Tele-Mental Health Program called as Tele-Manas in India. So youth engagement in mental health advocacy is growing also. There are platforms like the Mind Plan, It's Okay to Talk, which are coming up in India. And the public attitudes are improving too. So 37% of Indians now believe that mental illness is treatable, according to the 2017 survey. This is great. We have reached at least a third of Indian population. 2/3, we'll continue to work on. So how are things looking here? When India is improving, growing, where are we as the immigrant Southeast Asians in this country? So there is a 40% increase in help-seeking behaviors among Indian Americans since 2019. And growth in culturally competent providers, there are South Asian therapists that are coming up, there is Manmukti, there is Desi therapist directories. School and universities are now offering the South Asian wellness groups. And the community-based events, just like this, just like VPA and the social media campaigns are breaking the silence around mental health. So depression is categorized in their symptoms in subcategories. For example, emotionally, one could feel sad, one could feel hopeless, there could be feelings of guilt around it. Cognitively, one might be inattentive. Physical symptoms, what we also call it as the neurovegetative symptoms, is one might be sleeping less or they might be sleeping more. Their appetite could decrease and they might lose weight, and sometimes they eat emotionally and they tend to gain weight in those circumstances. Fatigue is one of the very common symptoms too. So it's almost like a phone that is charged 1% and it is refusing to recharge. They just feel tired all the time. Some of the other symptoms could be withdrawal. They could isolate from others, or they might be in the large groups and still feeling alone and numb inside. Some other factors could be suicidality, self-harm thoughts, and decrease in ADLs, not brushing, changing clothes, taking shower. They all become a challenge. A day-to-day life becomes a challenge. So when should one seek help? When the symptoms are lasting more than 2 weeks, that is identified with 5 predominant symptoms that I just told you guys about, along with 2 weeks of duration, that is the major depressive disorder. And one should seek help when the symptoms are lasting longer than that. If there is interference with the work, or they are not able to perform academically, their grades suddenly start declining, they're struggling with their relationships, that means that the depression is severe to the extent that their functioning is getting impacted. Or if somebody is having unsafe thoughts, suicidal thoughts, there is self-harm behavior. Non-suicidal self-injuries are very common, because they are trying to find an emotional release among themselves. But it is also known that these NSSI, the non-suicidal self-injurious behaviors, actually can accidentally result in suicides. So depression is of many types. Like I just said, there is major depressive disorder, there could be seasonal affective disorder where the depressive symptoms are more common during the winter time. Or there could be, the depressive symptoms lasting forever and there are no episodes. They are called as a persistent depressive disorder. Depression could happen once when females give childbirth. It is called as the postpartum depression. And there could be mixed symptoms with the anxiety as well. Sometimes there is catatonic depression where, there is psychomotor retardation in the body and you actually stop moving as much. Or, when there is, even between the MDD, there are 3 different severities called as mild, moderate, and severe, depending on how impaired one's functioning is. So when you start noticing anybody who's struggling with these symptoms, initially as a family, we can start guiding them with the coping skills. We can start helping them build the routines because that is something that gets lost pretty easily. Help them with the physical activity because that brings up the happy hormones in life, the noradrenaline, the adrenaline, those are the things that bring the joy, the motivation, and drive to continue. There's a huge importance of faith, prayers, and meditation. If you look at the psychotherapy techniques, they have actually started implementing mindfulness-based stress reduction strategies, mindfulness-based cognitive therapy, and these therapies are actually using the meditation as one of the strategies to help you feel calmer or be in the present moment. Connecting with the community and then help them foster their interests. If they feel emotional releases through their art, journaling, dancing. I think I was telling somebody, they're playing the music in the background, I might just start dancing here instead of speaking to them. That's my passion, right? And we have to use the culturally sensitive approaches, get the support, bring the community clinics in, give them the information about the hotlines that are available, give them the confidence that your confidentiality is protected. And there are various kinds of treatments available. Educate them. There is talk therapy, support groups, medication. Wherever you are at in wanting treatment, we will meet you there. I think we will get you there. And hopefully you will come to the point where you're more accepting to the kind of help that is available. Use the culturally matched providers or interpreters and normalize the mental health conversations in the family systems, okay? And involve those elders, those leaders, because they can be such a guiding and inspiration in our lives. So what are some of the treatment options for depression and other mood disorders? So like I said, there is psychotherapy, especially when the symptoms are mild to moderate. You can just start with the therapy alone. It does need to be more frequent, anywhere between weekly to every other week, because individuals tend to forget, if the duration or the, the sessions are not happening frequently enough. So for example, cognitive behavioral therapy works on the cognitive triangle or the cognitive triad. What's that triad? There is emotions, There are thoughts, and emotions and thoughts interplay into the behaviors. And we work on those negative thoughts and negative emotions to correct the behaviors, and that is what is cognitive behavioral therapy. Interpersonal therapy is more about the family dynamics and conflicts. So when we know that the depression is coming from the family dynamic relation issues or the family system issues, IPT or the interpersonal therapy is more effective. The dialectical behavioral therapy is more when the individual is struggling with the emotional dysregulation. There is poor distress tolerance, there is inability to maintain the relationships, and that is when DBT skills can be very helpful. Medication. So like I told you earlier, I think the receptors, the neurotransmitters that are usually involved are serotonin, norepinephrine, and dopamine. So the treatment also includes same medications that target those behaviors. So the first line agents are selective serotonin reuptake inhibitors, and some of the examples would be Paxil or paroxetine, Zoloft or sertraline, fluoxetine or Prozac, and there are a few. Usually well tolerated, some side effects, but they're short lasting. But if your symptoms are not completely addressed by those, then the psychiatrist might like to switch the categories to SNRIs, which are serotonin, norepinephrine reuptake inhibitors. And due to the involvement of norepinephrine, we have to watch out for your blood pressure, we have to watch out for your pulse, because they can get deranged. And what are some of the medications here? Venlafaxine or Effexor, Cymbalta, or duloxetine, Pristiq, or desvenlafaxine. And the last one that I wanted to bring up is, there are actually a few more, but bupropion, because that works on DNRI, which is dopamine norepinephrine reuptake inhibitor. Really great medication for depression, and it actually, the dopamine effect kind of brings up the motivation. So for somebody who's struggling with a lot of fatigue, a lot of lethargy, bupropion could be a very good choice if it is a pure depression. There is a new medicine that came out a couple of years ago, and that's called as Auvelity, which is a combination medication for bupropion and dextromethorphan. It actually starts working within a few days. So are all other antidepressants where they could take several weeks on a good effective dose, the Auvelity is actually, in the recent researches, have been told that it can start working within a few days. Sometimes we do need to include the mood stabilizers, atypical antipsychotics, even sometimes the thyroid supplements, because we want to either augment the effect of the antidepressants, or what we want to do is at least stabilize the mood, the irritability that is not getting addressed by the antidepressants. Lifestyle interventions are very important too. Sleep hygiene. Reduce your caffeine intake, go to bed in time, wake up in time, reduce your water intake after 5 p.m. So there are less sleep disruptions, during the nighttime to use the bathroom. Exercise, gut health is important, so your nutrition, what you're eating, impacts your mood as well. And then reduce your substance use. Some of the advanced or other somatic therapies, ECT has been there forever. I think the ECT was first time used in 1938, and it is for the treatment-resistant depression, and actually it is very effective in the elderly depression as well. Transcranial magnetic stimulation is the brain stimulation, non-invasive brain stimulation, the nerve cell stimulation for the resistant depression. The ketamine and esketamines are the dissociative anesthetics which are also used in the resistant depressive, and especially if somebody is suicidal and you want a rapid response. Some of the complementary approaches, like I said, could be art, music therapy. There are Ayurveda practices too. There are so many patients of mine who like taking ashwagandha for anxiety, for their sleep aids. And some of it could be through the peer support groups as well, because like I said, depression brings in the feeling of being alone. So what you want is having a community around you so that you don't feel that loneliness in this. This is a very important slide because many times I get contacted by my peers, my family members, or my friends that my kid is self-harming, what should I do? Outpatient care is successful only when somebody is stable enough and you can go and see your doctor for your med refills once in every few months. But if somebody is having any safety concerns, they do require other levels of care. But not many people know what those other levels of care are. So easiest way, somebody is willing to go to treatment, go to ER, and they will triage you based on the acuity of your symptoms. It could be any level of care that we are going to discuss today, but if somebody is not willing to go in, then call 911, 988, and there are local crisis, mobile crisis utilization teams as well that can come at your home and assess the individual to see if they need to go in. 988, I think with the recent laws and changes, I don't know if the funding is going to continue or if it's going to cut short, but so far it is still there. And what the other levels of care could be, if somebody is self-harming, but they are willing to stay in treatment, go to treatment, one of the cares is intensive outpatient programs. These programs are 3 to 5 days in a week, 3 hours a day, where the individual gets group therapy, individual therapy, family therapy, and what are the next levels of care, so support around that. The partial hospitalization programs are happening 5 days in a week, 6 hours a day. There could be 1 to 2 individual therapy sessions in a week, 1 to 2 family sessions or parent coaching groups, along with the group sessions. And then the next higher levels of care are inpatient and residential treatment. These days, the inpatient length of stay is usually around 7 days to 14 days. In 1970s or 1980s, it used to be about 2 months. With the insurance cuts, the stringent regulations these days, the inpatient duration has decreased a lot. So due to which the inpatient doctors do the rapid med stabilization in these times. So they put you on a med, they titrate the med quickly, and they figure out what's the next level of care, and they send you out. If you are safe enough to be able to go back to outpatient or PHP or IOP, great, they'll hook you up. However, if somebody is not safe enough to be able to be in the community, then they are advised to go to the residential treatments. What are these residential treatments? These are 24/7 monitoring units, and they could be locked or unlocked units, and the treatment duration could be anywhere between 30 days to 60 days, and in the long-term residential, it could be anywhere between 90 days to 6 months. So these are some of the resources like 988, Asian Mental Health Collectives, the NAMI Asian American Resources, the local clinics, and the translated materials. And if anybody has questions, I guess in the original slide I did give my phone number or my email as well. But if you'd like to contact me, please reach out to me on this email address, and I'll be more than happy to answer your questions. Thank you so much for listening today.
Thank you, Dr. Shika. Good afternoon, everyone. I'm Dr. Vinuta. Our next speaker is Dr. Nandini Gowda. She's an internist, obesity medicine specialist, primary care mental health, and addiction medicine specialist with 18 years of experience. She's an internal medicine program director and clerkship director of OptiWest, San Antonio Regional Hospital in Upland, California. Associate Professor of Medicine of Western University of Health Science in Pomona, California. She's also one of the chairs of National VPA, CME, and Health Education Committee. Dr. Nandini Gowda.
Thank you so much. Okay. Let me get out of this slide, if you don't mind. So I hope I don't put you guys to sleep. Everybody's in the dark currently. Okay, so my topic is menopause. So I don't know how much at least like everybody has either family members who are going through this or personal experience or wives for the men. So, and future wives and girlfriends for the younger generation. So I just wanted to talk about recognition and management of symptoms. Oh, this is going very slowly. Okay, let's talk about menopause. So what is menopause? This is a period where there's no menstrual periods for 12 continuous months. That's the time it's called permanent. It can, prior to that, it can be intermittent. And it occurs on average when women reach the 50 years of age. And if menopause occurs before 40 years of age, then we call it premature menopause. So just remember that. Like, I mean, it's usually on average women go through it at 50. And the one thing is, like, I mean, we have to talk about conditions like this. I don't think we should keep it internally. And we, as a culture, we're not very open about things like this. Like Dr. Shika Verma already mentioned, menstrual symptoms. We don't talk about it. And I think it should be made known, whether it's a male or a female or daughters, sons. Everybody needs to know. And we also, as parents, have to educate our younger generation. So, because like prior generations, some of them don't know how to educate others. Because if I ask my mother-in-law this question, she doesn't know. She just says, I feel hot. What is going on? She can't tell her own daughter what's going on. So this is something we need to stop this. We, at least we need to learn, and moving forward, we need to educate the young.
Yeah, they did. Just so you know. Yeah, that's why I did that.
Okay, let me move on. Okay, so there are two different kinds of ways people can attain menopause. That's either through the natural way, which is like everything in the body. There are genetic factors, whether it's age, and there's also lifestyle. The lower the body weight, you can achieve menopause earlier. Could be environment, and there are diseases as well. Like if people have cancer of any sort, if they go through chemotherapy, radiation therapy, it naturally alters the menstrual cycle, and it can cause them to go into early menopause. There's the other artificial way, which is post-surgical. We call that artificial because the ovaries are removed. As soon as, if there's ovarian cancer or ovarian disease, then as soon as that happens, people can go into menopause, where there's no period. So this is a little bit about the anatomy. I'm giving you guys an anatomy lesson. One is in the younger generation, as you can see, this is the uterus. And then you have the ovaries, cervix, the vaginal area. This is what I teach my students. But at the same time, like when they get older, the ovaries start atrophying. It becomes older, and it stops making something called estrogen, which is a very important hormone. Then you start having fat cells throughout the majority of the body's estrogen production instead of that because of this. So then estrogen. Naturally, what happens is that the estrogen decreases, then afterwards, ovulation becomes irregular, and I don't know if some of you have taken anatomy classes when you were in high school, and after ovulation does not occur, progesterone is not produced. Then, in turn, periods don't occur. So this is what women go through. It's called the late reproductive phase, early perimenopause, late perimenopause, early menopause, and late menopause. So these are multiple phases that women go through. So where periods can be like clockwork before, depends on people, and then it goes into early menopause where it can start getting irregular. Then later menopause, it gets even more. Then the perimenopause. Then afterwards, in early menopause, it stops. So gradually, people can have periods which comes every 3 months, every 6 months, then 8 months, then it stops altogether. Along with these, the periods, they start getting mood swings as well. A lot more people are gonna start noticing hot flashes and night sweats, and then you're gonna have like men complaining it's too cold, but the woman wants the temperature lower because she's flushing so much, because she's feeling hot. Because of that, she'll reduce the temperature. I always tell the women, at least like try to wear a sweater if you're feeling, I tell the men to wear the sweater because when the women are reducing the temperature. So there are multiple areas menopause affects the body, and people don't realize it because people always go, oh, now I'm feeling more, I don't know what's happening to me. I'm going through these mood swings. And like usually what happens is their partners don't understand the women what they're going through. And the partners need education as well, because many of them are like, my wife is so irritable now, and they don't understand it, what she's going through. She might be crying all of a sudden, or she's going to become more anxious with menopause. When estrogen drops, they can get dry eyes, dry mouth, and also there's dryness in other areas which affect sexual functioning. They can gain weight. They can have dry skin and nails. There could be bone loss, and thinning hair, brain fog. So and also you can have joint pains. You could have like back pain to other issues, which means before you never rested, you didn't have to rest, you could keep going when you were younger, but when you age, what happens is you might need to take a break. Go take a nap, or rest your back or joint, which you were not needing in the past. And especially this affects, I've seen it affect more the high functioning women. Women who are in higher careers, they notice it much more than a woman. For example, if you think about a housewife, they also need the same functioning, but a higher functioning woman, whether it's like engineers, doctors, or they're business women, they notice it faster because they're not able to make the same amount of decision they were in the past. So I just wanted to educate you guys about the things that women need to remember is also during all the changes that are happening is mammogram screening. Everybody needs to get it starting at 40 years of age, and we stop screening around 74 years of age. And pap smear screening, we always start at 21 years of age, and we stop at 65 if everything's normal. And I know a lot of Indian women don't get pap smears. I've seen them come from India and have not had a pap smear until they see me at 30 years of age. And that's when I have to tell them, you have to get a pap smear, and then I take them in. So it's not talked about. These are things I think women need to be aware of. Colon cancer screening. We start at 45 years of age for colon cancer, and we stop at 75 years of age. So I see a lot of people who, again, have colon cancer, they come to the end stage and then come in wanting treatment. The kids bring in their mom or even their dad, but in this, when I'm talking about the men. But definitely, that's something we have to be aware of. So bone density goes down with menopause. So that's one thing we start screening around 65. Unless a woman has reached earlier menopause, then we start screening earlier. And we always recommend everybody is vitamin D deficient. So we do recommend everyone to get some amount of vitamin D, whether it's like capsule, or if you want to do it through diet, that's also fine, calcium and vitamin D. And that's very essential for postmenopausal women. We also need everybody exercising. Women need to be walking, if not jogging. I don't need to expect everybody to jog, but at least walk. Start 10 minutes is what I suggest. Start 10 minutes per day, and then afterwards bump it up. Then if you can do later on, after you retire, you can go higher, twice a day. Because start slow, but keep moving. So management of menopausal symptoms. This, if any of the women go in, I always say, don't ever forget, you can always have a pregnancy in the middle of all this. And you think you're done, then I've seen oopsie babies happen. And because women come in and tell me all the time, they're like, oh, my cycles are irregular, I've already gone through this. And I'm like, no, you can still be pregnant. So they don't understand that. So I always suggest to them lifestyle changes. I've said, okay, if you're feeling chills all of a sudden, dress in layers. If you ever go into a hospital, you have a lot of women among nursing. And nurses you see them always holding fans or doing something else in the middle because of the hot flashes. And so things I always suggest is cold showers, carrying a fan, avoid triggers, like we are alcohol, caffeine, spicy foods, especially with our culture. So these are going to be a healthy way along regular physical activity is going to be a must. Good sleep for adults, our basic minimum is 7 hours. And if you could do 8 hours, that's fine, but at least 7 hours of sleep and cut down on screen time, because we've become screenagers. And with Netflix, and I'm also notorious for doing this, but as my family will tell. But that's something we all have to be cognizant about, because, kids have restriction, but why not adults? We need to start restricting, because as adults, we have to use screens, but when we come home, we can't, we are not able to cut down. So that's something we have to remember. Stress reduction. So one thing is like there's something called North American Menopause Society. They're very good about like women are experience they're like burning pain. They come to me, and then then I always tell them, okay, do you want to try hormones or do you want to try non-hormones? What's your method? And I notice like with our Indian culture, naturally everybody is like prefers natural method. Majority of our cultures or multi-ethnic cultures are like that. They want to do it naturally. Sometimes you can't. Sometimes you can go vaginal moisturizers as first line. But if that doesn't work, then I do prescribe them hormonal therapy. And you can always manage with topical creams. Now, for the majority of this will work only for dryness, but like if they have more symptoms, and I have seen women who are sweating like crazy in my office, they come in, they can't tolerate any of whatever they've tried for conservative measures. That's when I tell them, you might want to consider being on hormones. Mild symptoms, no need to worry, because you might just pass it through. Some people, it resolves after 10 years. So hormone has good and bad. There are benefits and risks. That's what we call it. But that's the reason I think it's very important for women to remember. Like, for example, I stay away from hormones if my patients have any kind of cancer. Because cancers, there's a lot of hormone-related changes, so I avoid it. But always talk to women if you guys see, and be aware that there are the benefits with it. They can control your symptoms. There's skeletal benefit. There is a slight heart disease benefit. And also in some kinds of, with estrogen only, there's a known, found to be some breast cancer benefit. But there are the other risks, on the other hand. It's like a weighing scale. So that's the reason this slide is very important, whether they can get clots, strokes, and there are some breast cancers which are dependent on 2 hormones, gallstones. There are pros and cons. There's always debate about whether they have dementia, they'll get dementia or not, but they say menopause itself, later on they'll develop dementia. So there's always studies. We need more studies on that. So we do have hormonal therapy for women who cannot tolerate hormones. I always go to like antidepressants or some of them, like venlafaxine. It helps them tolerate the symptoms that they're going through. That's basically what I'm trying to help them with. Or I try them on anti-seizure medications like gabapentin, or some of them, there's always a component of overactive bladder in women, and I do put them on medications called oxybutynin. There are newer medications which regulate the temperature control in the brain, and it's called VPA. There are other non-pharmacological methods which we don't have a lot of data on. That's for herbal, botanical, plant-based estrogen supplements like lima beans, soybean products, black cohosh, acupuncture. So these are things some of my women do try. Postmenopausal mood, sleep, and other health changes, I do recommend the same thing as any psychiatrist would recommend. Psychotherapy helps with mood changes and sleep disturbance. It's not only, but it doesn't help with the hot flashes. And they found clinical hypnosis. If people ever want to try that, it's only effective for short term. So I wouldn't recommend it for long term. I'd rather you go for like psychotherapy. So if you guys want more references, they're here. It's called North American Menopause Society. It's called NAMS. Anybody can look it up anytime. The Mayo Clinic also has some very good articles. WebMD has some. I know in our current generations, we have so much information overload, and you can't determine which one is good information and which one is bad information. These are at least legit sites that you can use. Thank you. This is my contact information. If you guys need to contact me for anything, just email me.
Thank you, Dr. Nandini Gowda. And now I would like to introduce Dr. Shweta Anand, board certified endocrinologist and our own Northern California endocrinologist. And she's a board certified endocrinologist and a member of the Golden State Obesity Society. And Dr. Shweta, you can please take over.
Good afternoon, everyone. Thank you all for being here. I'll try my best to keep you awake. Today, I'll be talking about a very important topic, diabetes mellitus, which has affected millions of people worldwide. Now, what is diabetes? It's a condition where the glucose levels are high in the blood. So normally when we eat, the stomach converts the food into glucose, and when the glucose enters the bloodstream, a pancreas produces a hormone called insulin. Now, insulin helps the glucose to enter into the blood cells through insulin receptor. If the pancreas does not produce enough insulin, or if there is insulin resistance, then the glucose cannot enter into the cells. And this can cause complications because of high glucose levels in the blood. Now, in 2021, approximately 550 million people in the world were affected with diabetes, and these numbers are trending up. As we can see here, the countries that are marked in black, India, China, and United States, are the ones that have the maximum number of people with diabetes. In the United States itself, 38 million people have diabetes. That means 1 out of every 10 people, and 1 out of 5 don't even know they have it. Pre-diabetes, which is actually a precursor of diabetes, is much more common, and 98 million people have pre-diabetes in the United States, which would be 1 out of every 3, and 8 out of 10 don't even know they have it. Now, among us, that is South Asians, diabetes is much more common, which goes hand in hand with coronary artery disease. Now, this chart in one study shows the relative risk of diabetes is much more common in other ethnic population. That goes parallel with the risk of hospitalization from coronary artery disease. Now, why is diabetes so common among us? It's because of genetic factors that make us more susceptible to insulin resistance. Altered body composition and fat distribution. Asians tend to accumulate more fat in the abdominal organs, which is called visceral fat, that causes insulin resistance even at lower body weights. Decreased lean muscle mass, which will impair the glucose metabolism and insulin sensitivity. Also, environmental factors, which includes migration from home country to other countries, itself can act as an independent risk factor. Now, also other risk factors include sedentary lifestyles, Indian diet, which is basically high carbohydrate, low protein, and high fat diet. And stress, of course, increases glucose levels by raising the cortisol. Now, there are two different kinds of diabetes. Type 1 diabetes, where the body does not make enough insulin. This is caused by autoimmune condition. It often starts in childhood, and symptoms come on quickly, and the main treatment is insulin. Type 2 diabetes is a condition where the body does not respond to insulin because of insulin resistance, and the common causes would be lifestyle factors like I discussed before, and genetics. It's more common in middle-aged people over 40, and symptoms develop slowly. Often it is called a silent disease. Symptoms start coming on if the sugar levels are very high or when complications happen. And it's mainly managed with lifestyle modifications, drugs, and eventually insulin. Now, this cartoon basically shows in normal people how the insulin helps the glucose to enter into the cells through insulin receptors. However, in type 1 diabetes, there is not enough insulin, so glucose cannot enter the cells. In type 2 diabetes, there is insulin, but the glucose cannot enter the cells because of insulin resistance. Now, the risk factors for type 2 diabetes includes family history, high BMI, inactive lifestyle, gestational diabetes, and age over 40. Also, other independent factors such as high blood pressure and high cholesterol can exist in diabetic patients. Now, type 2 diabetes can cause different symptoms when the sugars are high, which includes excessive thirst, excessive urination, unexplained weight loss, slow healing of the wounds, numbness and tingling of the feet, which can cause ulcers that don't heal, irritability, excessive hunger, and frequent infections. Now, hemoglobin A1C is an important test we use to diagnose diabetes and also to assess the glucose control for 3 months. Now, the way we use it is because the glucose attaches to red blood cells that has an average lifespan of 120 days, and we know hemoglobin is produced by the red blood cells. So that's how we use hemoglobin A1C as an average marker for 3 months. As we can see on the right, depending on the A1C, we can estimate the average glucose levels for 3 months. Now, the way we diagnose type 2 diabetes is basically by 2 different tests. One is hemoglobin A1C. As we can see here, the normal A1C is 5.7. 5.7 to 6.4 is pre-diabetes, and over 6.5 is diabetes. We can also use fasting blood glucose. Normal levels are 99. 100 to 125 is pre-diabetes, and over 126 is diabetes. Now, at least 2 of them should be positive before we can make a prompt diagnosis. Oral glucose tolerance test, we don't use it for regular diagnosis, we use it mostly for gestational diabetes. Now, among the complications of diabetes, there are microvascular complications where the diabetes can affect the small blood vessels supplying the eyes. It's called diabetic retinopathy, and this can cause blindness. And also it can affect the kidneys, a condition where protein leaks in the urine, and it can cause chronic kidney disease and end-stage renal disease if not treated early. It can also affect the small blood vessels supplying the nerves, especially of the feet and the hands, and this can cause numbness and tingling. This is called as diabetic neuropathy. It can also affect the major organs, especially the brain, where it can increase the risk of stroke, transient ischemic attacks, and vascular dementia. It can affect the heart, where it can increase the risk of coronary heart disease, and extremities, where the large blood vessels supplying the extremities can be blocked. This can cause claudication pain, gangrene, and in certain cases may even need amputations. Now, pre-diabetes, which is actually a precursor of diabetes, it's very important to recognize and treat this early, because if this is treated, then it can prevent the progression to diabetes, type 2 diabetes. Now, the way we treat it is mainly lifestyle modifications, regular exercise, at least 30 minutes of exercise per day, minimum of 5 days per week, eating, of course, a healthy, balanced diet, and weight loss. Even 5 to 7% of the weight loss from the baseline can reduce the risk of progressing to type 2 diabetes. Now, some of the smart food swaps we can make are trying to eat whole grain fibers such as brown rice, quinoa, whole wheat, millets instead of white rice, pasta, and then trying to pick smart beverages such as water as much as possible, herbal tea, unsweetened milk over juices and sodas and cokes, and try to restrict pastries only for special occasions. Now, a typical diabetic diet should comprise of lots of fruits, low glycemic index fruits, lots of vegetables, and whole grains, lean protein, especially I like plant-based protein, because plant-based whole food is an important diet for lowering insulin resistance. And different types of millets are very good because they have a lot of fiber and they are low in glycemic index, and they can be good sources of carbohydrates. Some of the examples are ragi, jowar, etc. Now, physical activity is very important for managing diabetes, and you could do anything that you want to do. You like dancing, swimming, skipping, but they should be like, you should do it in a way where it increases your heart rate, not just casual. The way we calculate the maximum heart rate is 220 minus age. For example, for a 40-year-old person, the maximum heart rate is 180. So the way you need to exercise is to increase the heart rate to 50 to 70% of that. So now diabetes medications are basically designed not only to control the glucose, but also to prevent end organ damage. So some of these medications, such as metformin, reduces the glucose production by the liver. They also, some of them medications which increase the glucose uptake by the muscles and the fat cells, and some of them actually increase the glucose excretion in the urine, so that way they reduce the glucose. Some of the medications support the pancreas to produce more insulin, and some of the medications control the appetite at the appetite center in the brain and reduce cravings. Some of the common medications, as some of you may have heard, is metformin. It's the preferred initial drug because it's very effective and it does cause some weight loss and it's easily tolerated and very cheap. The cost is very low. And there is all these medications in the first slide, they have a lot of other benefits in addition to lowering the glucose. Jardiance, Farxiga, and Invokana, they lower the glucose by spill the glucose in the urine. They are good choices for people with heart disease, heart failure, and kidney disease because they prevent the progression of these conditions. Now, you may have heard Ozempic and Trulicity. These are once-a-week injections. These are not insulin. They actually increase the insulin response to a meal. They slow digestion. They cause some weight loss. And they reduce the risk of heart disease and stroke. Now, Mounjaro is a newer one in the market, which is a very effective medication for people with excess body weight and glucose control. The second slide basically has older diabetic medications, although they're still used in some people. Glipizide and glimepiride, they basically help the pancreas to produce insulin, that's it. Now, Januvia is also used, but it's a very gentle medicine. We usually use it for people who are very fragile, they're at risk of sugar dropping too fast, or elderly population. Now, Actos is a medication that helps to improve the insulin sensitivity. Now, among the insulins, we have different forms. One, previously we had only vial and injection where we had to draw the injection and inject. It was too much of a hassle for patients, but now we have insulin pens, and we have very fine needles that don't hurt. Then we have insulin pump, and then we also have inhaled insulin. Now, checking blood sugar, it's very important to check the blood sugar because that's one way you know how food activity and medications will affect your glucose. Now, glucose readings can be checked by using glucometer or continuous glucose monitor, or CGM. Now, CGM has revolutionized glucose monitoring and diabetes care to a tremendous degree. Now, CGM measures the glucose in the fluid under your skin, and there are certain alerts you can set up for high glucose and low glucose. Now, among the CGMs, there are two big ones in the market. One is called Dexcom. It's basically a patch that goes on the arm or the abdomen, and it can measure your blood sugar throughout the day over 24-hour period, and it can tell you the spikes, the glucose drops, and it's very useful for patients to control their sugars better and to prevent dangerous low blood sugars. It can be used in conjunction with your phone or Apple Watch, so it's very convenient. We also have what is called as Libre. It is changed every 2 weeks. And the same thing, it helps you to tell you the 24-hour glucose control and the patterns. Now, insulin pump is a device where the insulin is contained in a reservoir inside the pump. It is connected to a tubing that goes under your skin. Now, insulin pump can be used along with CGM. It wirelessly transmits the glucose data to the CGM receiver of the pump. So they work together to regulate the glucose levels minute by minute. Now, the standards of care in diabetes include hemoglobin A1C, which we measure usually every 3 months, and the blood pressure, of course, with every patient visit, or you can also measure the blood pressure at home. Dilated eye retinal exam is usually done every 6 months to a year, and foot exam, where we use a fine filament to check the sensation of your feet. Now, also we check the urine protein test every 3 months to 6 months, and we have to check the cholesterol levels as well, because the cholesterol levels need to be tightly controlled in diabetics, especially diabetic patients who also have heart disease or stroke. So basically, diabetes health is in your hands because we can only give you recommendations, and since it is a lifestyle disease, you have to take it home and you have to do your part. So lots of research are going on in the field of diabetes. Now they are trying to find a cure for type 1 diabetes. Hopefully it will happen one day. Sorry, type 1 diabetes for which there is no cure as of now. So these are some of my resources. Thank you for listening. Thank you for your time.
questions from the audience?
I got everybody when I fucked up when I go. Estírame. Can you get her mic? There we go. Good. Yep. It's on. It's on. I think you turned it on. Yeah. They turned it off, the other
Sorry,
one, accidentally.
I'm audible, right? You can hear me?
Yep, yep. It's on. It's on. We're on. It's been on. It's on.
Can you turn on the lights, please?
All lights. Okay. Okay. Copy that.
Go ahead.
I'm audible. Yeah, I can.
Okay, now we can hear you.
Yeah, first of all, thank you to all the doctors who came here and presented. This was very useful information. And my very first question is, are you guys going to share these slides with us for future reference?
Yeah, we can. I mean, I think somebody's taken a video. She's one of the organizers.
Yeah, thank you so much for doing that. And my question is to Dr. Shika. When you talked about the medication for depression regarding antidepressants and things, what side effects can we expect if we opt for the medication?
Sure. So I think for the serotonin reuptake inhibitors, the most common ones are nausea, headaches, some tummy aches in the beginning. They usually go away in about 1 to 2 weeks. Some of the uncommon ones could be if you see bruises on your body and you do not remember getting hurt. Just make sure that, you let your doctors know. They will run some quick blood tests and the medication can be discontinued and it goes back to being normal. It can lower, some of these meds can lower the seizure threshold, so especially if somebody has history of seizures or they could be at risk, we have to monitor for those as well. In SNRIs, I think I already said that the norepinephrine component does require the pulse, the vitals to be monitored as well because the blood pressure can rise and so can the pulse. So if it is above the range where we usually like it to be, then sometimes we have to either modify the doses, decrease the doses or discontinue the medication. Wellbutrin has some relevant, Wellbutrin is bupropion, my apology, and the Wellbutrin actually is used, there is a relative contraindication if there is eating disorders, like if somebody is especially purging, you don't want to do that because Wellbutrin in itself lowers the seizure threshold and purging because of the electrolyte imbalances and all of that can increase the further risk of seizures too. So these are some of the things that we got to keep in mind. Wellbutrin does lower the appetite also. So similar to the stimulant medications, Wellbutrin is one of those meds that can lower the appetite. So in eating disorder patients, we have to be careful when we are prescribing that medication.
But it is nothing major that if one wants to opt for medication, one shouldn't be thinking twice or be worried about going for medication or...
Every medication comes in with benefits and side effects too, right? If you look at the actually list of side effects that one can have from Tylenol and ibuprofen, they're longer than the antidepressants category. But I have to say, all these antidepressants do come in with a black box warning for the suicidal ideations. But I do want to go back to the study when it was done back in 2004. It was done on the paroxetine Paxil medication in 2004. And what they found out was if 100 people were taking Paxil and 100 people were taking placebo, 3 to 4 out of the Paxil group had suicidal thoughts, and 2 out of the placebo group had suicidal thoughts. So then how we do the research is the number needed to treat NNT, or the number, the one that causes the side effects. So the risk was marginally increased, but the black box warning came in. What happened as a result? Patients who were stabilized for several years on antidepressants, their doctors ended up discontinuing that medication abruptly. What we saw was, right after that 2004, if you look at the literature, the suicidal attempts actually increased right after the 2004. And that was essentially because the stable patients were discontinued because of the worry, the fear that the suicidal ideations might happen. So it's a chicken and egg thing, right? Depression came first or suicide? But we still have to let the families know that, yes, this is a black box warning that exists for these meds.
One last question regarding a follow-up or something. I know it depends on the medication that a person is prescribed, but is there a minimum set of duration that a person must and should take the medication for? Is it like minimum for 6 months, or is it any shorter duration? Or
So the SSRIs, SNRIs take good 4 to 6 weeks, if not 8 weeks, on a good dose to be effective. And I think that is where patients lose hope. So what happens is they are started low on the doses because doctors don't want to give the side effects immediately, with the hope that if the medications are tolerated okay, the doses will be increased. But it could take good 2 to 3 months to get to that effective dose and to have the benefits. Once somebody has, let's say, major depressive episode for the first time, the single episode, the guidelines are that one should be on the medication for 6 to 12 months after that first episode before you start considering to lower down the doses of medications. If somebody has had 2 or more episodes of depression, then the treatment could be anywhere between 2 to 5 years. If there is a treatment failure to one serotonin reuptake inhibitor, the other guideline is that you should try 3 SSRIs before switching the category, moving on to SNRIs or moving on to a different medication. But again, many times in my situation in clinical cases, if there is no benefits at all from 2 SSRIs, I sometimes do move, switch the categories because really, I think patient is struggling and they're losing hope on the medications. We want them to be stabilized more quickly. So treatment duration actually depends on what dose you are on, if it is your first episode, or if you are into multiple episodes. Duration of treatment can be longer if it is 2 or more episodes. Did I answer your question?
this is very helpful. Thank you so much.
Of course.
I have a question and a comment. My name is Dr. Lalita. I'm a practicing cardiologist. So this is like habba to me. What I mean to say is all these venues live to my door. Diabetes, then menopause and stress-induced heart diseases. So first of all, excellent talk, and you cannot keep enlightening the community over and over again. So I had a couple of questions and a comment. When it comes to menopause, right? Up until menopause, your risk of heart disease is way less than that of men, because estrogen has a heart protective effect. But once we approach menopause and we keep growing older, your risk of heart disease equals, if not exceeds, that of men. So we as an Indian community, we are, if not 3, but 5 times more prone to heart disease. So very important, I see people around me all the time, despite so much education over and over again, we do not pay attention to screening. Screening both in terms of diabetes, weight, etc., etc. And then add to another thing is, we are very behind in terms of acknowledging diabetes, like Shweta said, right? The Indian diet. I think we as women have a control at home, shopping right, eating right, portion control, all that. And then to this day, westernization has ruined it for us. The age-old mudde and the Indian, what we call, when I talk to my dietitians at home, and Shweta can attest to this, the reason the thali came into existence was because this is portion control. You have an excellent balanced diet which has small components of everything. Don't respect keto. Most for the young people, high protein, high keto, useless, nonsense. It has not taken anybody anywhere in terms of heart disease. Stick to the Indian diet, stick to mudde, upsaru, kolisaru, everything's portion control. I cannot relate to how important this is. Whatever, and one other advice to the cool people in the community, whatever has been acknowledged as being cool is not cool. I argue with my daughters all the time. What you mimic as cool in the 20s, you pay a price in the 40s and 50s. So it's extremely important to, your culture, stick to your culture, listen to your moms. Provided moms listen to us. So this is very, very important. You have to do that. So I had to add to this, to all of the excellent talk that we had. And one other thing, a question for Shweta. I see this a lot in my practice. I'm seeing a lot of young kids between 18 to 25. lot of anxiety, palpitations, and all that. I personally, when they come to me, we're having a mom and a child talk. I'm not being like a doctor. Literally, I'm telling them, they're literally having their phones when they talk to me. So if you can attest to this, how has social media addiction increased mental health? Or I should say, made it worse for you? And have you seen literally like a proportional rise of this problem? A comment, and then how do you address this at home? Thank you.
Thank you, Dr. Lata. I think I have seen a significant rise actually, especially after the COVID, there was no going back. Initially, like the pediatrics guidelines were that we should have 1.5 to 2 hours of screen time in a day altogether. And here come COVID, and they were doing schooling for like 7 to 8 hours on the screens. So there is no going back from there. I think, and it is not going to go back to where it was 5 years ago. What we do need to teach our kids is the social media aptness and ability to be able to contain it through the time. I do tell my patients all the time, at some point you have to come down and say, as a family, we are going to put our devices down around 9 o'clock in the night or 10 o'clock in the night. Have that designated time, leave them at one place, and all of you, for your own sleep hygiene, go back. I think it is going to come with the teaching, but yes, there is a huge rise in the anxiety. There is a huge rise in, I have also seen that isolation around the COVID time and returning back to school, especially kids who were in middle school and they had to go back to the high schools, things were so much harder for them. And a lot of them ended up continuing with the online schooling because the social anxiety was so profound in them. The treatment for anxiety disorders is go back to your fears, face your fears slowly and steadily. The more you walk away, the bigger the fear is going to get, right? Unfortunately, there are so many students right now who are still in the online schooling system just because they are not able to return back. And when they come to us, by the time their social anxiety is already so big, they are always on the screens. If not doing their schoolwork, they're hooked up with these online friends. And there is such a rise, actually, I want to say, even in the cyberbullying and the crimes related to it. I have had so many patients where the feds are involved because these younger kids were getting involved with the adults, on these social media websites, which has been pretty significant. Yeah.
Thank you. It's a huge problem because it's a huge problem, I know.
It is a huge problem. It is a huge problem. And I think that is why, we have to coach the social anxiety. Yes, kiddo, we are going to get you there. Let's return back to school, maybe by 1 hour a week, 1 hour in a day for the 1 week, and then increasing it to 2 hours. But we have to return back to the normal. We have to make you successful when you're 25, and keeping you home is not going to get you there.
I think we as physicians are seeing the technology, what you call the price for the technological advancement. Like how we saw the Industrial Revolution, we're seeing with this thing obesity, because sitting for more than 5 hours is considered to be equivalent to sugar diabetes, right, Shweta? That's a big problem with the technological. So thank you, ladies. Thank you.
Okay, on behalf of VPA community, I would like to thank all our distinguished speakers, Dr. Shika Verma, Dr. Nandini Gowda, and Dr. Shweta Anand for their time, effort, and wealth of knowledge they have shared with us today. And special thanks to all of you who made it now in spite of being sleepy and paid attention. And also thanks to our other committee members, Dr. Lata Sunil Kumar, Dr. Shweta Anand, of course, Dr. Nandini Gowda. And special thanks to Yamini Gowda. Without her, this would not have happened. Okay. And thanks to Mr. Dhananjaya and Mr. Murli, our VPA President and Vice President.
Just in case they run something through the.
Yeah, I got it. It's on pause on Netflix.